I didn't realize. 0720
Da.
255
Da.
199.
Okay. Thank you.
Thank you. Please let me know if something happens again. Okay, so slide, you in the slide of morphology. This one?
Yes.
Okay. The definition?
No.
No. So, aortic stenosis represents a pathological constriction that can occur above the aortic valve, below the aortic valve, or at the level of the aortic valve. And the valvular obstacle in front of the flow from the LV cavity to the ascending aorta is the most common form of aortic stenosis. 70% of aortic stenosis are valvular. By etiology, the aortic stenosis may be congenital or acquired. Aortic stenosis is the most common valvular heart disease in industrialized countries, and the most frequent etiologies of the valvular aortic stenosis, which is our subject for today, so the valvular aortic stenosis, the most common etiologies are degenerative, rheumatic, and congenital. What about the degenerative form or the calcific form of aortic stenosis? In this case, the cusps are very rigid, are very thickened, with a lot of calcium on the leaflets, but without commissural fusion. The commissures are these spaces between the insertion of the leaflet on the annulus, on the aortic annulus. Okay, so here is a commissure. We have 3 commissures between the 3 aortic cusps. In calcific aortic stenosis, the commissures are free. You can see the space between the commissures. And the pathophysiology of this type of aortic stenosis is very similar to that of atherosclerosis, based on inflammation in early phases and late phases being associated with calcification, which is not a characteristic of atherosclerosis. So only in early phases, the pathophysiology of aortic stenosis is similar to that of atherosclerosis. What about the valvular aortic stenosis in patients with rheumatic disease, rheumatic heart disease? In this case, as you can see in this image, there is an inflammation which will lead to commissural fusions. So we cannot see the commissures anymore. The valvular orifice will be a central one, and as you can see in this image, there is retraction and thickening of the free edges of the cusps, and calcified nodulus may be found at the free edge of the cusps on the leaflet body. So the valve will be only a central orifice. No free commissures will be seen. In congenital aortic stenosis, and the most common form is bicuspid aortic valve, there is a fusion between 2 of the 3 normal aortic valve leaflets. In this case, you can see these 2 leaflets that are fusioned with a raphe, with a central raphe, leading to 2 cusps, as you can see, and this is happening during the valvulogenesis. Please remember that congenital aortic valve stenosis is the most common congenital heart defect, most frequent in males than in females, and is very predisposed to degeneration, to fibrosis, to calcification, and is a frequent finding that bicuspid aortic valve is associated with stenosis or regurgitation, or both of them. But in some cases, the bicuspid aortic valve may be normally functioning. too. It may happen. What about the pathophysiology of valvular aortic stenosis? So the reduced opening of the aortic valve during systole will lead to an increase of the intraventricular pressure meant to overcome this obstruction, and this will lead in time to concentric left ventricular hypertrophy. The left ventricular hypertrophy is associated with delayed left ventricular relaxation and reduced left ventricular compliance, which are characteristics of left ventricular diastolic dysfunction. And in time, the left ventricular diastolic dysfunction will lead to elevated left ventricular filling pressures. Moreover, there is an imbalance between the oxygen demand and the oxygen supply because the muscle is very thick and the vessels are just the same. They are not more numerous if the muscle is hypertrophic, and this will lead to myocardial ischemia. Myocardial hypertrophy associated with myocardial ischemia will lead in time to myocardial fibrosis and myocyte degeneration. So this left ventricular hypertrophy, which in early stages is a compensatory mechanism meant to normalize the pressure that affects the left ventricular walls, the pressure put on LV walls, will become so this compensatory mechanism will decompensate later, resulting in left ventricular dilation, symptoms development, heart failure, and death. Are you there? Can you hear me?
Yes.
Okay. So please remember that in early stages and for a long period of time, the left ventricle in patients with aortic stenosis is not dilated. It's only presents only with concentric hypertrophy. The concentric hypertrophy will lead to a small left ventricular cavity. However, in late stages, this afterload mismatch, which means that the ventricle has to continuously overcome an increased afterload, will lead to a myocardial dysfunction, a reduction of the myocardial contractility, which in early phases is reversible. So if we if we replace the aortic valve, then the LV function will return to normal. However, if the replacement is late, then the myocardial contractility may be irreversible. The pathophysiological sequence is the following. In the beginning, there will be left ventricular hypertrophy and left ventricular diastolic dysfunction. This left ventricular diastolic dysfunction will lead to increased pressure into the left ventricle in diastole and into the left atrium and backwards to the pulmonary veins and capillaries, leading to pulmonary hypertension and in late stages, quite late stages, to right heart failure. This is a very important slide. There are many elements on this slide that are essential for you to understand the management of patients with aortic stenosis, and some of these things you will find these things in questions during your final exam. So it is important to remember that the patient with aortic stenosis, even with severe aortic stenosis, may remain asymptomatic for many years. Once the symptoms occur, the risk of death of a patient with severe aortic stenosis increases from less than 1% per year to more than 2% per month, which is a lot. In fact, 75% of the symptomatic patients with severe aortic stenosis will die within 3 years unless they receive a valve replacement. Which are the three classic symptoms of aortic stenosis that initially occur on exertion: syncope, angina, and dyspnea. You can remember as SAD. So the patient became very sad as soon as symptoms occur. This is because its prognosis will become very bad with the occurrence of symptoms. In this slide, you can see the survival of patients with severe aortic stenosis in the asymptomatic stage and after the symptoms onset. And as you can see, as long as the patient is asymptomatic, the survival is still good. However, with dyspnea, the survival will be reduced to 2 years. With the syncope, with the occurrence of syncope, there are 3 years. The prognosis is of 3 years, and with angina is of an average of 5 years. Okay, so when dyspnea is present, then the prognosis is very bad, and the expectancy of life is reduced to an average of 2 years. This is happening if the patient is only on medical treatment, and everything changes if the patient will, if surgery will be performed and the patient will benefit of an aortic valve replacement. Then, as you can see, the prognosis will improve dramatically. Okay, so the only type of treatment that can change the prognosis in a patient with aortic stenosis is aortic valve replacement by surgery or by percutaneous implantation of the aortic valve. But anyway, without changing the aortic valve and replacing it with a prosthesis, the prognosis after the symptoms onset remains very bad, irrespective of the type of medical treatment that we are using the patient. The main symptoms, as I told you, are represented by dyspnea on exertion and paroxysmal nocturnal dyspnea or even orthopnea in advanced stages. And these symptoms are due mainly to left ventricular diastolic dysfunction. Exercise angina is the consequence of the imbalance between oxygen demand and supply, plus or minus atherosclerotic stenosis on the coronary arteries. Okay, so angina can be present in a patient with aortic stenosis in the absence of coronary artery stenosis, and in this case, it may be due only to that imbalance between left ventricular mass and the supplying coronary artery, which are not increasing, are not more numerous as the left ventricular mass increases. Moreover, syncope during exertion may be due in a patient with aortic stenosis to an insufficient oxygen supply to the brain due to an excessive peripheral vasodilation or to transient left ventricular failure with exercise. So during exercise, left ventricular function may decrease transiently, not permanently, and in this case, the cardiac output will decrease, and then the oxygen supply to the brain will decrease too. Remember that sudden cardiac death may occur in patients with severe aortic stenosis during exercise, and a significant percentage of these patients will present an arrhythmic event due to left ventricular hypertrophy. What about the physical examination? Of course, in late stages, when right ventricular failure is present, the patient will present with, at inspection, with jugular distension. On palpation, the pulse is slow rising, late peaking, and low amplitude, has a low amplitude. it's the parvus et tardus type of pulse. And in this case, when this type of pulse is found, it means that the aortic stenosis is severe. However, in patients in whom severe aortic stenosis is associated with aortic regurgitation, the regurgitant flow will augment the ejected flow from the ventricle, and then in this patient, the pulse pressure may seem normal, may be normal. With severe aortic stenosis, radiation of the murmur to the carotids will lead to a palpable thrill on the carotid arteries in some patients, not in all of them. Moreover, the cardiac impulse may be sustained and become displaced inferiorly and laterally with the occurrence of left ventricular failure. A systolic thrill may be palpated in the second right intercostal space or in the suprasternal notch and transmitted along the carotid arteries in severe aortic stenosis. What about the auscultation? As you can see, the first cardiac sound is due to the closure of mitral and tricuspid valves. Mitral will close first and then tricuspid. And since in a patient with isolated aortic stenosis, for instance, mitral and tricuspid valves are not affected, the first sound may be normal. What about the second sound? The second sound is due to pulmonary and artery and aortic valves closure. Just a second, please. And this is why in patients with calcified and immobile aortic valves, this second sound may become soft or even inaudible. If the patient presents with an important left ventricular hypertrophy, then a fourth sound can be heard at the apex due to vigorous atrial contraction. When the cusps are still mobile, an early systolic ejection click may be heard. What about the murmur? It is the most easy to be recognized murmur because it is a harsh one. It's very easy to hear this kind of murmur. And it is diamond shaped. So its intensity is increasing until mid-systole and then decreasing. And it radiates bilaterally to the carotids. However, it is best heard in the second right intercostal space. Please remember that the murmur does not correlate with the severity of aortic stenosis. Another thing is that with calcified aortic valves, the systolic murmur, which will be loudest at the base of the heart, but high frequency components of this murmur will radiate to the apex. This is the Gala-Verdun phenomenon, and it will make difficult to differentiate these high frequency components of aortic stenosis murmur to that of mitral regurgitation. However, the mitral regurgitation murmur is pansystolic. It starts even before the opening of the aortic valve in the isovolumic interval, and it ends after the aortic stenosis murmur. It's longer. It starts before and it stops after the aortic stenosis murmur. Of course, it is not easy to make all these differences, particularly in the beginning when we are starting to do auscultation. And this is why it will be, of course, it is useful to have this knowledge, because you can use this not only on auscultation, but also when you will understand and you will be able to make an interpretation of the spectral Doppler waves because these durations will help you to differentiate an aortic stenosis envelope from a mitral regurgitation one. So the differential diagnosis of an aortic stenosis murmur will be done with that of mitral or tricuspid regurgitation, with that of hypertrophic cardiomyopathy, or with that of a hyperdynamic state. If the patient has fever, for instance, a systolic murmur will be heard in the second right intercostal space, but not due to an aortic stenosis. It is just a high output passing through the aortic valve and leading to this murmur. Then angina in a patient with aortic stenosis should be differentiated by angina due to coronary artery disease. Sometimes the etiology of angina is due to both coronary artery disease and the imbalance between oxygen demand and supply. So to differentiate between the two, it's difficult and not very useful, because anyway, if the patient presents with angina, a coronary angiography should be made. So here on this slide, you can see the main diagnostic tests that we should use in a patient with aortic valve stenosis. Some of them are routinely used, others are used more rarely in selected patients. So the EKG, the X-ray, and the echocardiography are the most commonly used diagnostic tests in patients with aortic stenosis. Lately, with the advent of percutaneous implantation of the aortic valve, computed tomography became also quite often used, because it gives us some important information in this type of patients, and we will talk a bit later. Cardiac magnetic resonance is dedicated for selected patients, and usually it is used to better characterize the myocardial tissue, to see if there is a lot of fibrosis, to see if there is amyloid within the myocardium, but it's dedicated to selected patients. And finally, catheterization of the heart, the retrograde catheterization of the heart, to image the aortic valve and to measure the left ventricular pressure, is not routinely used. However, it may be useful if non-invasive methods are not adequate, or are discordant, are not leading to a clear conclusion. Let's take a look at this EKG. And let's see what do you see on this EKG. Let's discuss a bit this EKG. Who wants to describe it? Can you hear me?
Yes.
Please try. It's not a difficult one. It's just the quality is not so good. However, I think you can see the main
Left
aspect.
ventricular hypertrophy.
But yes, let's read it as we previously did. Rhythm, heart rate, axis, morphology. What kind of a rhythm is that?
It's a sinus rhythm.
It's a sinus rhythm, yes. What about the heart rate?
75.
Sorry? You said 70?
Approximately 70, 75.
Yes. What about the QRS axis? You can see very well, and it is right here in lead 1, we can see how tall the R is. However, it is positive, the QRS complex in D1 and in AVF. So in this case, because we cannot see very well lead 1, we will see that the QRS axis is normal, but only in this situation, because we cannot see the are in this limb lead. What about the morphology? You said left ventricular hypertrophy. What else? Which is the argument for, or which are the arguments for left ventricular hypertrophy?
The QRS complex in V4, V5 is quite a length.
Sorry?
Amplitude of V4, V5 is high.
Yes, but do you have an index? A diagnostic index for left ventricular hypertrophy?
Sokolov-Lyon index?
Yes, with a cutoff point of
35.
yes, 35. Yes, and in this case we do have 35. It's clear. What about the STT changes? What do you make of them? What do you think?
Are secondary to the left ventricle hypertrophy.
I agree. And why is that? Why are they are not primary changes?
Because of the morphology of T wave and
What kind of a morphology?
the second slope of the T wave. It's
So it's easier to say that the T wave is asymmetrical. It's easier to say that, okay? It's not a symmetric T wave, right? Or not? So
Yeah.
it's not symmetric. You're right about the slopes. Yes, this is slope is slower and this is more rapid. So the T wave is not symmetric. When it is symmetric, a primary change is rather expected than a secondary one. And then we have the downsloping ST depression. This kind of change with downsloping ST depression and negative T wave is the strain pattern of the STT changes in patients with left ventricular hypertrophy. To strain means to stretch, to force. So due to the increased LV mass and the LV hypertrophy, there is a forcing of the left ventricular wall, which is reflected in this type of changes, ST downsloping depression and negative T wave. Of course, we can find on the EKG left atrial abnormalities due to left ventricular diastolic dysfunction, left bundle branch block, or AV block. The AV block may be due to the calcification of the aortic valve, which may affect the His bundle, or atrial fibrillation. What about the X-ray? Usually, in patients with valvular aortic stenosis, usually the cardiothoracic index is normal or maybe slightly elevated. Usually, the left inferior arch is rounded and elongated. And well, in this case, it is also the apex is above the diaphragm, so it may suggest that is a right ventricular dilation in this case. But if it's not an advanced stage of the disease, then you will see an elongated left ventricular arch which meets the diaphragm. When there is an increased left ventricular, an increased cardiothoracic index, so when there is cardiomegaly, we should suspect that aortic valve stenosis is associated with aortic regurgitation or with mitral regurgitation. So with a regurgitant lesion, valvular lesion, that have contributed to to the cardiomegaly, to a dilated left ventricle. Sometimes a post-stenotic dilation of the ascending aorta, this is the ascending aorta, the aortic arch, okay, may be found particularly in patients with bicuspid aortic valve. Left atrial dilation with a linear contour of the cardiac gulf, or pulmonary venous hypertension with a large area of projection of the heels bilaterally, may indicate pulmonary hypertension. But the most useful test, diagnostic test in patients with aortic stenosis is the transthoracic echocardiography, because it will confirm or will reject the presence of aortic stenosis. It will give information about the localization of the aortic stenosis, on the etiology, on its severity, on LV function. It will reveal associated heart valve disease. It will give us an estimation of the aortic root and ascending aorta dimension, because if there is a dilation of the aortic root or of the ascending aorta, then maybe it will be necessary to change to replace not only the aortic valve, but also the ascending aorta. And of course, it will reveal other associated abnormalities. For instance, aortic coarctation, which is a common association, a common abnormality in patients with bicuspid aortic valve, and should be always searched for. Okay, what about the left ventricle in this image? What do you think? It's a normal or a dilated one? It's a normally functioning or a hypokinetic one? Let's talk about the function. Maybe it's much more difficult to estimate the size of the left ventricle, but what about the function? Do you think it's a normal function in this case of the left ventricle?
Maybe hypokinetic.
Yes, because if you remember the ventricle that I showed you a few days ago, the walls were closing, were very close to each other during systole. And in this case, you can see that during systole, they remain very far one from the other, you see? So this ventricle is not closing during systole. Yes, this is a severe left ventricular dysfunction in a patient with an aortic valve stenosis, a severe aortic valve stenosis. This is the case of a calcified aortic valve with a severe stenosis, representing a severe obstacle to in the way of the flow from the left ventricle to the ascending aorta. And in time, the left ventricle will become hypokinetic, but if it's not too late, by changing the valve, the function will recover if it's not too late and if the dysfunction is not irreversible. Here is a focus in a 5-chamber image on the aortic valve. You don't see anything moving here because it's a lot of calcium and the valve opening is so small that you cannot see it. It's a very restricted valve opening in a patient with heavily calcified leaflets and severe aortic stenosis. This is a 3D transthoracic echocardiography showing the aortic valve in two planes which are orthogonal at 55 degrees. This is a transesophageal echocardiography. So we can see the image at 55 grades and then 145. So here is the aortic valve with the 3 cusps. This is the right, to the right ventricle. This is the left, and this is the non-coronary. here, to that cusp corresponds a sinus of Valsalva with the right coronary artery. To this cusp corresponds a sinus of Valsalva with the left coronary artery, and you can see the opening of the left main here. And this is a cusp corresponding to the interatrial septum without a corresponding coronary artery. It's the non-coronary cusp. Okay, and here you can see the same aortic valve, but in a longitudinal projection. This is the ascending aorta. And this is a valve. However, as you can see, it is not opening. It's a very restricted valve opening. In a normally functioning aortic valve, the cusps should be very thin, as two very thin lines that are opening very well, which is not the case in this patient. With the transthoracic echocardiography, we are able to estimate the aortic valve area using a formula which is called the continuity equation. In this formula, or the principle of this formula, is that the volume of blood entering the aortic valve should be the same with the volume of blood going out from the aortic valve. Okay, I'm not sure that it's important for you to learn this formula, but the elements that we need in order to estimate the aortic valve area are the diameter of the left ventricular outflow tract and the velocity time integral of the envelopes of flow into the LVOT and out of the valve. I will not go further in this subject because I think it is more important for you to know general principles of diagnosis and treatment in patients with aortic stenosis. Is too much, I think. If you want, we can discuss about this tomorrow if you want, but I think it's too much. Okay, so now what are the criteria that we are using to assess the severity of the aortic valve stenosis? And you should remember these parameters because a velocity through the aortic valve of more than 4 meters per second, and here is the envelope, and here you can see there is a velocity, a maximum velocity, which is more than 4 meters per second, indicates severe aortic stenosis. An aortic valve area calculated by the continuity equation below 1 centimeter square or below 0.6 centimeter square over meter square, so index to body surface area, below 1 or 0.6 when it's indexed to body surface area, and a mean gradient along the valve of more than 40 indicates severe aortic stenosis. What is the maximum gradient? What is the mean gradient? I will just explain you because I don't know if you know. Do you know what mean and maximum gradients represent? I think that you already the course of on mitral stenosis was presented, right? Are you there?
Yes.
Yes, we're here, but
Do you remember something from the mitral stenosis course? What is a gradient? What represents a gradient? A pressure gradient.
the difference in the pressure.
Yes, between two chambers
Yes.
that are separated by a small orifice. So the flow is passing from a chamber to the other chamber through this orifice, and there is an acceleration of the flow when passing through the orifice. Using the maximum value of the velocity of the flow through the orifice, we can get the difference in pressure between the two chambers. Okay, for V square. This is the formula for the pressure, the maximum pressure gradient. It was presented, this formula, or not? So if you, in this case, this envelope represents the flow passing from the left ventricular cavity into the aorta through the small orifice represented by the aortic valve stenosis. The high velocity is due to the fact that the valve has a restricted opening. With a normal valve, with a normal opening, there is no pressure gradient. The flow passes freely from the left ventricle to the ascending aorta. There is no difference in pressure on these sides, the ventricular side and the aortic side. But if the valve has a restricted opening, it will be a small orifice, and then the flow will go through the small orifice into the aorta, and at the level of the small orifice, there is an acceleration of the flow. This acceleration, in this case, leads to a maximum velocity of 4 meters per second, and in this case, based on this maximum velocity, we can calculate a maximum gradient of 4 V square, where V is 4 meters per second. Okay? Did you know that the formula? It was presented, or no? Just a yes or a no, please.
I don't remember. I don't know if any of my colleagues remember.
Okay, but do you understand the principle? So if you don't have to remember this formula, because nobody will ask you the formula. It's just for you to understand that using the velocity of the flow through a stenotic orifice, we can calculate the difference in pressure between the two chambers. But this is the maximum gradient. As you can see here, we are using the mean gradient. The maximum gradient, by tracing this envelope, which represents the flow, all the velocities of the red blood cells passing from the ventricle to the ascending aorta in systole. This is the duration of systole, and this is the velocity of these red blood cells. The maximum velocity is more than 4 meters per second, 5 maybe. By tracing the contour, we will get the machine, the echocardiograph, will present both the maximum pressure gradient and the mean pressure gradient, and you can see it here. The maximum pressure gradient is calculated by this formula, 4 multiplied V squared. The mean pressure gradient is calculated by averaging all the maximum gradients along the contour, all the gradients along the contour during systole. It's like a mean value of this instant. In each moment, there is a difference in pressure between the left ventricle and the aorta, and this difference in pressure changes along the systole, the duration of the systole. A mean value of all these instantaneous gradients represent the mean gradient. Maybe it's difficult. Just remember the value that the mean gradient over 40 represents a criterion for severe aortic stenosis. Just read this afternoon aortic valve stenosis and ask me tomorrow if there is something that you don't understand or if you want to know more about something, okay?
Yes.
So let's go further because otherwise it's a lot of information. Okay, this difference, these gradients can be calculated by echocardiography, and this is what we are doing every day in our practice. But this kind of information can be obtained also by using catheterization. And here you can see the catheterization curves of the left ventricle and the pressure curve into the aorta. And as you can see, during systole, the intraventricular pressure is much higher than the aortic pressure. And this is because the pressure into the ventricle has to overcome the obstacle represented the aortic stenosis. So the pressure into the ventricle will increase very much as long as the stenosis is present and will disappear after replacement of the stenosis with a prosthesis. But before that, we will have a much higher pressure into the ventricle than into the aorta. Here you can see a systolic aortic pressure of 120, but an intraventricular pressure gradient of 200. So the difference in pressure between the aorta and the ventricle represent the pressure gradient that I previously presented you as assessed by echocardiography. This is the pressure gradient. A problem with the catheterization is that the two gradients are not simultaneously measured because the catheter is introduced into the ventricle and then withdrawn into the aorta. So it will measure in two different moments in time the pressure into the ventricle and the maximum pressure into the aorta. And this is a limitation of this kind of evaluation of pressure gradients because they are not simultaneous. In order to get simultaneous evaluation, the same mean gradient may be calculated, which means to assess a mean of all the instantaneous. You see, for each moment in systole, the difference in pressure represents a gradient. In the beginning of the systole, there is no difference in pressure between the aortic valve and the left ventricle. Then the left ventricle contracts in order to overcome the obstacle represented by the aortic stenosis, and this is why the pressure into the ventricle increases, whereas the pressure into the aorta is not so much increased. This difference in pressure at each moment is an instantaneous gradient. The mean of all these instantaneous gradient represent the mean gradient. And this is the best way to assess the pressure gradient between the left ventricle and the aorta using catheterization. Only one thing I would like to tell you about the assessment of the aortic valve. You know, there are some situations. So let's go back to the parameters of severity. I told you that a Doppler velocity above 4 meters per second, an aortic valve area below 1 or 0.6 when indexed to BSA, or a mean gradient over 40 are parameters of aortic stenosis severity. However, there are some situations when the mean gradient is low, is not above 40, so the difference in pressure between the left ventricle and the aorta is not so high, despite the fact that the aortic stenosis is severe. And when calculated by the continuity equation, we will get a value below 1 centimeter square. This situation may be explained by the fact that the cardiac output is low. So low that a significant pressure gradient is not able to be physiologically achieved. What does it mean? Imagine that a patient has severe aortic stenosis and LV systolic dysfunction. If the patient has LV systolic dysfunction, that means that in the presence of a severe aortic stenosis, the left ventricle will not be able to increase its pressure so much. It will increase his pressure, but not so much because his contractility is reduced. So the difference in pressure between the ventricular cavity and the aorta will not be so high, despite the fact that the aortic stenosis is severe. Do you understand the concept?
Yes.
This is called low flow, low gradient aortic stenosis. Okay, so the left ventricle, the myocardium of the left ventricle is already affected, has a problem due to the aortic stenosis, because it's tired to increase the intraventricular pressure against an obstacle, or due to something else, another pathology, another myocardial pathology. Irrespective of the etiology of left ventricular dysfunction, the fact is that in the presence of aortic valve stenosis, it will not be able to increase the intraventricular pressure as much as a normal ventricle would do. And that means that the difference of pressure between the left ventricle and the aorta will not be so high in such a patient as compared to a patient with a normally functioning left ventricle, even if the severity of the aortic stenosis is the same in both patients. Okay, so we have this category of low flow, low gradient aortic stenosis. Moving forward, another thing that you should know is that not only in patients with reduced left ventricular ejection fraction this phenomenon can happen, but also in patients with normal ejection fraction. For instance, let's imagine a patient with severe mitral regurgitation. In systole, in the presence of a severe aortic stenosis, the left ventricle will increase its pressure, the pressure within its cavity. Because the pressure within the cavity is very high, the severity of a mitral regurgitation, which was previously mild, along with the increased severity of aortic stenosis, this mitral regurgitation will increase because it's easier for the ventricle to force the mitral valve and to send the flow back into the left atrium than to force the aortic valve, which is very calcified, and to send the flow into the aorta. And this is why, along with the increased severity of the aortic valve stenosis, an increased severity of mitral regurgitation will occur. Since there is a significant and more significant mitral regurgitation, that means that the cardiac output will decrease because the quantity of flow that is sent forward into the aorta will decrease. Since the cardiac output and the flow through the aorta will decrease, the gradient will decrease too. Do you understand?
Yes.
Okay. You will read. Please read. It's not so easy, but it's not so difficult either. You have just to pay attention. Read this afternoon the aortic stenosis, and then we will discuss again tomorrow if you want. How can we be sure that if the patient has a low mean gradient and the aortic valve area is below 1 centimeter square, how can we be sure that there is not a mistake? Maybe it's a mistake that the aortic valve area has this value because we are basing our estimates on a measurement of the left ventricular outflow tract and 2 envelopes. Maybe something was is wrong. Maybe one of these measurements is wrong. So what we can do is to give dobutamine to these patients to see what happens if the contractility of the left ventricle increases. And if the contractility increases and the gradient increases too, then it means that it's a truly severe aortic stenosis. Okay. What about transesophageal echocardiography? Transesophageal echocardiography provides additional evaluation of aortic valve morphology, planimetry. It helps us to assess the mitral valve, to better assess the mitral valve, and to assess the aortic valve before TAVI or others or surgical procedures. The BNP, or the natriuretic peptide, is useful to predict the symptom-free survival and outcome in patients, in asymptomatic patients, and may be very useful to determine the optimal timing of intervention. So, if in a patient with severe aortic stenosis, we have the patient says he has no symptoms, and the BNP is low, then we can wait and do a watchful waiting of the patient. It's not necessary to replace the valve as long as the patient has no symptoms and the BNP is low. The multi-slice computed tomography can give us additional information on the dimensions and the geometry of the aortic root and ascending aorta, and the extent of valve calcification. A correlation has been demonstrated between the severity of valvular calcification and the severity of aortic valve stenosis. And as I told you, cardiac magnetic resonance can be useful to better characterize the myocardial tissue and to prove, for instance, myocardial fibrosis. We don't do stress testing, exercise stress testing in symptomatic patients, never, because there is a high risk of sudden death. However, if the patient is asymptomatic, then we should do an exercise stress testing in order to prove this asymptomatic status. So exercise testing is recommended in apparently asymptomatic physically active patients with severe AS for unmasking symptoms, dyspnea, or an abnormal blood pressure response. So if there is a fall in blood pressure during the test, that means that there is a reason to go for an earlier intervention in this patients. That as well, exercise stress echocardiography may provide prognostic information in asymptomatic severe aortic stenosis by assessing the increase in mean pressure gradient and change in LV function during exercise. No medical therapy for aortic stenosis can improve the outcome compared with the natural history. Of course, if the patient presents with heart failure or with coexisting hypertension, then medical treatment should be used in order to treat heart failure symptoms or to normalize the blood pressure value. But we have to pay attention because in these patients with aortic stenosis, the risk of hypotension is high. The only effective treatment for aortic stenosis is removal of the mechanical obstruction. And you should remember that aortic valve replacement is indicated for survival benefit, improvement in symptoms, and improvement in left ventricular systolic function in all patients with severe and symptomatic aortic stenosis. However, an indication for aortic valve replacement may be due not only based on symptoms, but also based on LV function assessment, because the valve should be replaced not too early, because if the patient is asymptomatic, the surgical risk of replacing the valve is higher than the natural risk of the patient. I told you that in the asymptomatic phase, the mortality risk is less than 1% per year, and instead the risk of the surgery is higher, but not too late when the left ventricle is too damaged. Therefore, another indication for aortic valve replacement, and I won't go there, is left ventricular dysfunction. So in patients with an ejection fraction below 50, a replacement of the aortic valve is also recommended. What about the type of intervention? Surgical aortic valve replacement should be considered primarily in low or intermediate risk patients and in patients with severe multivessel coronary artery disease, because at the time of aortic valve replacement, the bypass surgery will also be performed, whereas a transcatheter approach will be considered primarily in patients with prohibitive, high or intermediate surgical risk based on current guidelines. And no valve replacement is recommended for patients with a life expectancy of less than 1 year. This is a biological aortic valve that can be implanted percutaneously. The implantation of this aortic valve can be made through the femoral artery, through the ascending aorta, to the level of the aortic valve, and you can see here the catheter. The valve is passed along the catheter and it's deployed here. You can see it's the balloon, a balloon is inflated and the valve is positioned here at the level of the aortic valve. I will stop here. I will send you the PDF of this course, and please read it again until tomorrow, and let's discuss tomorrow in the beginning of the course of tomorrow.